thanks very much, Margarita, and Scott for the invite. It's fantastic to be here as usual. This talk gave me a little bit of headache because trying to work out something, empower people within the area that you're going to take the message back is always quite challenging, because often in the academic units we have all the resources available, so it's quite easy to just decant all the work and get it out there, and somebody makes it happen and you end up with a polished product and you can do your job at a first world level. And it's really when you have to get involved in the training of people that are outside to represent you that your eyes open up to what the realities is of the needs out there. And specifically in South Africa, our needs are way different. So the brief was you're in a level 1 district hospital in an underserved area of the world. Now, I was meant to be talking after Alberto and the second talk on the lab investigations. You kind of have to assume that you know that by now. So these are all built on each other. But if you look at South Africa, this is a rough sort of layout in terms of the spinal surgeons available in South Africa. And you'll see that they're roughly condensed within the economic centers of the country, kind of implicating the lucrative nature of being a spinal surgeon in those areas. And I'm going to tread on a little bit of dangerous ground here, because there's a lot of financial incentive in a lot of things that happen out in the world today. Nonetheless, if you take that specific graph and you stratify it, oh sorry, this thing is very quick, stratify it for, that was incidentally for about 56 million people. So if you stratify that, take those 3 causal centers away, in South Africa you have under 30 spinal surgeons serving 25 million people. And this is just spinal surgeons, so it's not doctors. So our doctors per 100,000 people work out somewhere between 30 and 50. And us in the training units are then meant to empower these doctors to go out and be efficient and be able to actually stream them down. Now, another step back, we're going to look at the burden in South Africa, which is not much different than in Botswana and Namibia, as my colleague Alex alluded to earlier. So this is from worldmap.org, and you can in fact see the prevalence of HIV in these countries. Back that up with TB, you've got a very much an unholy alliance between the two, creating a lot of work for a lot of people within the medical fields. And then trauma, our good friend. And I like to speak about the commodity of trauma, because ultimately our trainees get a lot of experience specifically in cutting and dealing with trauma, and ultimately become very polished surgeons, sadly said. But MBAs and interpersonal violence certainly gives us a lot of work. Now you can look at that. Now add 23 people and 1 goat, and luckily this is World Spine Care, not World Veterinary Care, but still, you're dealing with large volumes of people. And often, apart from the MBAs, the interpersonal violence, I mean, I just pulled this out of my database last night. So there's a cervical gunshot, a thoracic gunshot, and a lumbar gunshot. And what do you do when you run out of bullets? You plant a flag, yeah. So all it needed was a little red flag to be more specific, and you certainly would have gotten the point, as he did. The last is degenerative disease and deformity. So deformity often is partitioned into the pediatric group, it's scoliosis, but in adult deformity obviously plays a big role, but then it's very closely linked to the degenerative disease excuse me, that we see. So those always take the back burner beyond the trauma and the infections that we deal with. And this is just the audit of my own spinal practice in a tertiary unit in my elective theatre. So this is elective theatre, not emergency theatre. And I ended up doing 42% degenerative work, of which you can argue that a lot of those were quite urgent, cervical myelopathies, etc. But if you look at the rest of it, which was trauma, infective, malignancies, and a little bit of degenerative work, ultimately these pathologies occupy a lot of what we see in the public service. Now, who's more dangerous? I often ask that question within the South African environment. To date, more people die annually in the United States that is, from toaster-related injuries than has ever died from shark attacks in the world. But still, I've had an interesting encounter with the great white, and do not want to repeat that again. The black mamba, almost near 100% mortality, and the spinal surgeon, certainly responsible for a lot of suffering within the world. Now, so let's go back here. The myth of the spinal patient. So how we train our people within South Africa is we say, here you are young doctors, we empower you with the way to look at x-rays, do lab tests, examine your patients, go out. But because we do it the way we do it, The myth is that initial presentation has got to end with spinal surgery. There's no way about it. No matter what you've got, if you've got a backache, you've got a bit of digit, that's where you end up. Spinal surgery. He's got to look after you. But that's not true, because there is, in fact, a world of spine care in between those two that is really not taught to the masses. And in fact, I'm going to add on to that and make it very lethal, albeit not lethal most of the time, but very potentially lethal at the end of it, and then take the myth away and say, well, this is the algorithm as it should be. Initial presentation, a lot of work done on you, and only then do you get to the shark, who hopefully can fix you for the right indications. So when do we operate? Very, very simply. Only three reasons: instability, neurology, and deformity. You take those three indications, that blankets everything that we need to do in spinal surgery. And we're going to take that deformity group, we're going to shove it out a bit, because the brief was a little bit on emergencies, and therefore I'm going to look at instability and neurology as emergency indicators for spinal surgery, and how you actually get confronted with that within the level 1 area. Right, where are we now? So this thing flies a little bit. Okay, so firstly, instability. If we suspect that the spine will not be able to withstand the physiological loads, it needs to be fixed. All right, the shark can get to you, we can fix it. Right, neurology. If the patient has significant neurological fallout, and if the neurology is progressing, I'm a neurosurgeon, so I'm very much partisan to the spinal cord and the brain. So if anything starts going south in that area, I want to know about it very quickly, because time is spine. It's a very common saying within the spinal cord fraternity. And lastly, deformity, and I marked it in blue because we're going to put it on the back burner a little bit. We're not going to worry about that too much, because it generally gets dealt with on an elective basis. Alright, so how do we fix it? Surgical surgery? Well, we stabilize the instability, we decompress the neurological structures, and we correct the deformity. Easy as that. Yeah. The problem is, if you're in a level 1 district hospital in an underserved area of the world, and these things present to you as a crisis, your biggest role is in fact recognition, not management. Recognition. Okay, we're going to move the red flags. You've been told these numerous times today already, and hopefully it'll be repeated a few times as well, because the emphasis can't actually be overemphasized. And again, if you look at there's a list of red flags, as we all have, and if you look at the surgeries I did in my elective theatre again, 58% of these were in fact via the red flag nature of presentation, with systemic illnesses, chronic steroid use, thoracic pain, night pains, etc., the infections, the traumas, all those type of things. So it's so relevant from the ground up all the way to the tertiary centers. Now, what is an emergency? The one thing we cannot fix is the spinal cord. Perhaps I should put in yet there, because the Elon Musks of the world and the feelings of the world is really trying very hard to try and come up with solutions for this. But as it stands, we cannot fix it, and therefore we have to vigorously protect the spinal cord and recognize neural compromise or instability with potential neural compromise by means of history, clinical examination, and special investigations, which include imaging and lab tests. And which of these modalities do we in fact have at our level 1? So 20 minutes is just too little time. In fact, a day is too little time to go through all of this in detail. So I really want to highlight 2 concepts for the level 1. And hopefully you guys can take this away. Touch on anatomy first. So anatomy of the spinal cord is the cord itself. And we know if there's a problem with the cord, we call it myelopathy. Yeah, so it's got a distinct set of presentation, like symptoms and signs. And if you have a problem with your nerve root, we call it a radiculopathy. Yeah, a root problem and a cord problem. But both of these we examine by virtue of their motor presentation, their sensory presentation, and how they affect the reflexes. So motor, sensory, reflexes, always in those 3 brackets, and they give you all the answers of what you need. Now here's where it's going to get a bit complicated. Neurogenic versus spinal shock. So there's a couple of big terms here, and I'm around for 2 days, so if anybody wants me to define these better, I'm happy to do that, but I really, really want you to take it on. So, shock. What is shock? You hear on ER and on Grey's Anatomy and on Scrubs, all these medical programs, the patient is in shock. Well, shock is in fact when your body cannot get the blood or the oxygen in the blood to the essential organs, which is the heart, the lungs, the brain, etc. So the body can't get it there, therefore you are in shock. And there's various reasons for shock, very obvious. Cardiogenic shock, the pump stops working, so the blood's not getting there, you are in shock. Hypovolemic shock, you don't have enough blood, the blood's not getting where it needs to be. Neurogenic shock, so how do you get in a situation where you don't have enough blood pumping through essential organs from a neurological cause? Well, it's because all these little blood vessels in your body get innervated by the nerves, and if they suddenly get cut off, let's say through a spinal cord injury, all these vessels dilate and the blood ends up in your legs. It falls down where gravity wants to take it, and it doesn't get to the to the essential organs. Now we recognize this from a simple blood pressure and a pulse, and obviously at various degrees of level of consciousness. But it's important for any primary care doctor, just doctor or front room or trauma doctor, to recognize this. Shock, we all get taught this. Now, somebody coined the term spinal shock, and everybody got confused. So how does spinal shock fit in with this whole hemodynamic thing about blood getting to organs, etc., etc.? Well, it's a nomenclature problem. It's named wrong. It should have been called spinal crisis. And it's this spinal crisis that I want you to recognize. Because this refers to the complete cessation of neurological function below a level of injury. But this presentation itself can be temporary. And you have to be able to recognize it, because if you catch it in the temporary period, you can potentially fix somebody. And I'll elaborate. So how do we do a reflex? How does a reflex work? So I tap the knee, there's a message, it gets sent on the peripheral nerve, it arcs in the spinal cord, zip, makes a turn, comes back and makes my leg kick. No, that's a reflex arc. At the same time, that same message takes a run up the spinal cord, has a chat to the brain. It says lots of parts in the brain, and it sends a message back down, and it gets modulated. So the reflex is within control. For example, if I pick up something with my bicep, my tricep relaxes. And I didn't think about that before. It's worked out for me by virtue of this modulation. Now, let's say you get a spinal cord injury, bang. Something whacks your spinal cord. And it unfortunately makes a big hole or gap in your spinal cord, and you are a quadriplegic patient. There's now a big gap in your spinal cord. Now, the brain cannot talk beyond that gap, and it cannot receive impulses beyond that gap. But this patient, a complete patient or a quadriplegic patient, in fact has no motor function below that level. They've got no sensory function below the level, but they do have reflexes. Why is that? Because that piece of tissue, spinal cord that's remaining, still has got a blood supply. It can still arc a reflex arc. Right, so that's important. So there is reflexes. Now, in spinal shock, it differs. It differs. So you get a whack on the spinal cord, there's a bad injury, and in this spinal shock situation, every single cell below the level goes dark, stops working. We don't understand why. I'm sure there's clever people who might be able to explain why, but for now, we don't completely understand it. But what is the implication of that on our examination of the patient? They will have no motor function below the level, they'll have no sensory function below the level, and they'll have no reflexes. Okay, so you find somebody, they've had a bad cervical injury, in myelopia, you examine him and there's no reflexes or sensory motor function, he is in spinal shock. And why is this a big deal? Because he could be normal. It could revert back. And that spinal cord itself, it's not giving you the information that it would in a quadriplegic patient, because that patient, unfortunately, has his die cast. It is what it is. And a case in point, I saw probably about 2 years ago now, a 14-year-old boy on a Saturday afternoon who broke his neck in a rugby match. He presents to me as a quadriplegic patient, but my registrar said he's in spinal shock. We aggressively managed him, and he walked out of hospital. All right, so urgent, aggressive management. And there's a couple of things that we can do to help these cases. But the point of this whole thing is to recognize this. And please, come and catch me outside. I'll gladly explain this because it's a lot of information. Motor sensory reflexes. Now, what is emergency and what is urgent surgery? So this is just a guide. I mean, this differs in each practice really. But I was actually just like to focus on the top two and to say, well, what is the things that we as surgeons need to be made aware of and need to address within the first hour or 2 hours or 6 hours for that matter. So we put in there bifacet dislocation of the neck, which is a common presentation, but essentially it's spinal cord compromise. Whether it's collapse of metastasis, or it's a dislocation from trauma, or whether it's even a stab of the spinal cord, you have to be made aware of that very urgently, and a decision is going to be made because time is spine. And then on the south side of things, you have the cardiac equina syndrome. Touch on that in a second. All the other ones you can see, while spinal infections also take very seriously. So any infective condition there, considering that the meninges is one continuum and you can get meningitis, etc., aggressively needs to be treated. But once you have reduced a fracture, or if you've managed to control somebody on a spinal board or control a neck, time is now on your side, and you can actually then manage them within the reasons or realms of your facilities available. But it's those top ones, the threatened emergency spinal cord, that's such a big deal. So the reduction of the C-spine infection, and I put this single slide in here because this is not what the talk is about. But Alex and I have often lamented the fact that the ATLS, the ACLS, and the APLS all treat you this incredible resuscitative efforts on people. But the simple act of reducing a spine is not in there. I mean, you have a security guard that can work a defibrillator, but you can't have a medical officer work a cone caliper and reduce a neck. And this is something that you guys can take note of and perhaps try and look into and ask and design workshops. And I'm very happy to come and show you guys and help you and teach you, because to reduce a neck can make all the difference for individuals potentially a quadriplegic or not. And there's just an example of somebody who walked out of hospital. Bifacial dislocation is reduced and ultimately fixed. But in that reduced position, the spinal cord is in a happy place. It's not being pressed anymore. It's now being saved. And now time is on my side. I'm now in control of that situation. But if I unreduced, like Alex showed this morning, waits 2 weeks in a peripheral area where it just could have been reduced, would have made all the difference. The cardiac equina syndrome, the horse's tail as it's called, it's still central canal, but these are all peripheral nerves. And why do we make a big deal of that? Well, if you look on the right-hand side there, the little nerve rootlets that's still present in the canal as we go lower down is the S1, S2, S3, S4, and these all innervate the bowel and bladder and the control of that. So if you've got loss of control of your bowel and bladder, it's a big deal. And they don't respond very well to a delayed management. So if you lose your bowel and your bladder, it unfortunately takes a lot of time to come in. And the spinalis team will tell you how debilitating that can be. So just the interesting thing about medical legal cases reviewed since the year 2000 for cardiac equina, and they found the lack of investigation of the rectal exam was the definitive factor whether plaintiffs were found guilty or not. And you have to do a rectal exam if the word cardiac equina is used, if bowel and bladder features, because the perianal sensation and anal tone, in fact, gives it away. And if that is the case, if there's a decrease in tone or if there's a decrease in sensation, emergency. And they say, put your finger in it, you put your foot in it. And that certainly has proved to be there. We've had a nice review on the cervical spine, so I'm not going to go through those again, because I did want to touch on some imaging and just show you some examples of potential cases that you could see. The assessment of the traumatic cervical spine is something that needs to happen in any facility. It needs to be accurate. And it's something that's very routinely put out, and you can find it quite easily on the internet and on any resources. So we are using bony examinations in this primary care facility to deduce ligamentous injury. We don't have an MRI, we don't have a CT, so we can't actually make too many assumptions, except the bone examination has been defined over many years, and the way it distracts, it shifts, it slides, gives us a lot of information. Couple that with your history examination, and I promise you 95% of times you'll have your diagnosis. The blinking owl sign we mentioned, this is a patient of mine. You can see the absent pedicle. Well, acute backache had to be metastatic disease, didn't it? This is a 16-year-old girl, presents to us with severe mechanical backache, very similar to the case Alberto showed. And you can also see the eating away of the body there. This is tuberculosis, end of the day. Always two views, AP and the lateral. So, interesting mistake. If you look at this X-ray, I actually put this up at a meeting of young registrars, all just starting out in their training, and I asked them, well, can you guys name me 3 things that is concerning you within this X-ray? And they were, I don't think they were very keen. Perhaps I could have gotten in there. But number one, if you look at the top, those 2 little pipes, that's chest drains, intercostal drains. Right, that's normally suggestive of quite a violent injury. Number 2 is that rib head is loose. Can you see that? So that's again very suspicious. Why did that rib dislocate? And number 3 is the interspinous distance. So if you see the distance between the 2 spinous processes, it's very much widened. But very normal looking if you just glance your eyes over it. It doesn't, and there's a reason why the radiologists want us to do 2 views, because you can often be misled as to what you're seeing on just one view. And in fact, there was never a lateral done on that patient, and that's the MRI scan. So it's a dislocated spine, right? Seemingly very innocent on just the AP X-ray. Right, last, or almost finished, the 24-year-old male, he fell down a flight of stairs, neurologically intact, but had severe neck pain. Look closely, and you can actually appreciate the fracture there. We have the rule of Spence, with the open mouth, giving us the overhang. This is a simple part of your basic trauma X-ray. You can in fact see the way that those edges overhang, and that in itself has got a definitive measure. If it's more than 7 millimeters, it actually suggests that there's ligamentous instability and this needs to be addressed. And it was right. The CT showed a complete destruction of the ring, and it had to be fixed. Now, here's a case of a patient, and I just had to show this at World Spine Care, presenting with mechanical backup. Now, if you ask all the spinal surgeons you've come across in your life, you'll hardly ever find somebody that needs a L1 to L4 instrumented fusion. Being done very straight, having screws pull out and caps come loose. It's just a terrible operation. This is a prime example of somebody who came from initial patient to shark and had a very bad operation. And in addition to the very bad operation, there's also that little, no, it's not wires, it's the gift that keeps on giving. It's the chronic sepsis from the retained swab. So this patient ran out of medical aid and it came across my door, and I had to go and fix that. So I'm afraid that it was bitten. Remember, a fool with a tool is still a fool, says Grady Booch. Finally, spinal patients. This world of spine care needs to be implemented, and we are really excited to be part of this movement. Alex, specifically all the work he's done in Namibia, getting this ethos within that area. But I think South Africa, we often think, because we have so many and more facilities and more developed spinal centers, that I wouldn't say it's above that, but that you can ignore that. And I think that's a very, very grave mistake. And I'll personally be driving that. So, summary, if you're a level 1 district hospital, your job is to accurately diagnose the problem by virtue of the history of the clinical examination. Recognize that acute emergency situation, whether you can deal with it by means of reduction or stabilization, it depends on the level of that surgeon, because you can get quite a few handy surgeons within the peripheral hospitals, but ultimately you need to know when you need to refer as soon as possible. I thank you for your time.